بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة، أتمنى أن تكونوا بخير وعافية. محاضرتنا اليوم راح تكون عن موضوع الفاريكوز veins. First, I'd like to remind you of the venous anatomy of lower limbs. As you know, the venous system of the lower limbs is divided into the deep venous system and superficial venous system. Okay, starting with the superficial venous system, the greater saphenous vein and lesser saphenous vein both arise from the dorsal venous arch on the dorsum of the foot. The great saphenous vein begins from the dorsal venous arch on the dorsum of the foot. It ascends anterior to the medial malleolus on the medial aspect of the leg. Then it will continue on the anterior medial aspect of the thigh to terminate into the femoral vein at the fossa ovalis 2 cm below and lateral to the pubic tubercle. Short saphenous vein arises from the dorsal venous arch at the lateral aspect of the foot. It ascends posterior to the lateral malleolus to empty into the popliteal vein in the popliteal fossa after penetrating the deep fascia. Now, in this diagram, we see here the great saphenous vein before it enters or before it empties into the common femoral vein at the groin. It receives many important branches. Okay? Now, the deep venous system of the lower limbs. As you know, the deep venous system is located below the muscular fascia, okay? And it serves as a collecting veins and the outflow from the extremity. The deep veins of the lower extremity consist of axial veins which follow the course of major arteries like common femoral vein, superficial femoral vein, popliteal vein, and tibial veins, and the intramuscular veins. The deep veins account for 80 to 90% of venous return, while the superficial veins account for only 10% of the venous return from the lower limbs. Perforators or perforator veins. They connect the superficial venous system to the deep venous system at various points at the ankle, mid-leg, below the knee, and thigh. They travel from the superficial fascia through an opening in the deep fascia to enter the deep veins. They are guarded by valves, so the flow is unidirectional from the superficial system to the deep system. Any reversal of flow in perforators will lead to varicose veins. Now, venous valves. They are most prevalent in the distal lower extremity, whereas as one proceeds proximally, the number of valves decreases to the point that in the superficial and in the superior and inferior vena cava, no valves are present. Venous valves prevent reverse flow in the veins. They ensure that blood is pumped from the superficial to the deep venous system and back towards the heart during walking, so they allow unidirectional blood flow. unidirectional blood flow from down up and from the superficial to the deep system. Now, venous return from the legs is governed by, influenced by many factors. First, calf muscle bump. The return of blood to the heart from the lower extremity is facilitated by the muscle bump function of the calf, a mechanism whereby the calf muscle, functioning as bellows during exercise, compresses the gastrocnemius and soleal sinuses and propels the blood toward the heart. This mechanism is very important. It is called the muscular venous pump or venomuscular pump. It's very important in the mechanism in the venous return from the lower limbs. As you notice here, during relaxation, the venous pressure in the lower limbs is about 20 millimeter mercury, while during contraction of the calf muscle, this pressure will increase to about 80 to 10 millimeter mercury. Okay? Now, other factor that influences the venous return from the legs is competent valves. The normally functioning valves in the venous system prevent retrograde flow, whether in the superficial system or in the deep system. This will help in the venous return and to prevent retrograde flow. Other factors which affect venous return are gravity, arterial pressure, and thoracic pump. But here we will focus on calf muscle pump, what is called muscular venous pump, and normal venous valves. Now, starting with varicose veins. By definition, varicose veins are abnormal, enlarged superficial veins, tortuous, twisted, widened, or lengthened. They are bulging under the skin surface due to defect in the valves within the veins themselves. So, varicose veins, abnormal, enlarged, superficial, dilated, or elongated veins with abnormal valves. I would like to mention some venous terms which are commonly used. First, spider veins or telangiectasias. They are small intradermal varicose veins, 0.5 to 1 millimeter in diameter. So they are small intradermal. Second, reticular veins. They are subcutaneous dilated veins about 1 to 3 millimeter in size. Third, varicose veins, more than 4 millimeter in size. These are the common venous terms used in clinical practice. Okay. Now, etiology of varicose veins. We have two types of varicose veins: primary varicose veins and secondary varicose veins. Regarding primary varicose veins, the exact cause of primary varicose veins is either congenital weakness in the venous wall or congenital absence of valves within the veins themselves, or congenital valvular incompetence. While secondary varicose veins, mostly they are due to venous obstruction, especially in the deep system. The most common causes are DVT, pelvic tumor, retroperitoneal fibrosis, obstruction of venous return, pregnancy, and AV fistula. Now, what about classification of varicose veins? The universal classification is called CAP classification: clinical, etiological, anatomical, and pathophysiological classification. I want to focus here only on the clinical classification, okay, which is widely used in the clinical practice. We have grade 0 to grade 6. Grade 1, only telangiectasia or reticular veins. Grade 2, varicose veins. Grade 3, edema. Grade 4 is pigmentation. Grade 5, healed ulcer. Grade 6, active non-healing ulcer. Of course, grade 0, no visible or palpable signs of venous disorders. This classification, CAP classification, is used to classify venous disorders in general, whether varicose veins or chronic venous insufficiency. But here I focused on clinical part of this classification, which is commonly used in clinical practice, and it is easy to remember. What about the pathogenesis of varicose veins? In this diagram, I tried to simplify the pathogenesis of varicose veins. First of all, any etiological factor of varicose veins, like defect in the venous wall, valvular incompetence due to congenital weakness, like deep venous obstruction, any etiological factor will lead to enlargement of vein. Enlargement of vein will lead to valvular incompetence. Okay? Valvular incompetence, again, it will lead to enlargement of vein. So, the venous pressure inside the veins, I mean the superficial veins, will increase due to defective valvular function and due to venous enlargement. So the pressure inside the veins, superficial veins, will become high. Okay. Another mechanism, when calf muscle contracts, when calf muscles contract, and we have incompetent perforators, so the blood will flow in a reverse way from the deep system to the superficial system through a defective valves in the perforators. This is called the dynamic pressure. Both these two mechanisms, calf muscle pump through a defective perforators and enlargement of veins with valvular incompetence, both these mechanisms will lead to venous hypertension. And when venous pressure inside the superficial venous system increases manifolds, this will lead to clinical manifestations of varicose veins. So, to simplify, two mechanisms: venous enlargement and valvular incompetence will lead to an increased hydrostatic pressure. Second mechanism, muscle contraction, I mean the calf muscle, with retrograde blood flow from the deep to the superficial, will lead to an increase in the dynamic pressure. This mechanism also will contribute to venous hypertension. This venous hypertension leads to clinical manifestations of varicose veins. Okay, now, what about the incidence and prevalence of varicose veins? About 15% of males over 18 years old suffer from varicose veins. About 30% of women over 18 years old suffer from some sort of venous disorder. Varicose veins increases with age, being present in more than half of the population by age of 75. Now, what about the risk factors of varicose veins? There are a lot of risk factors. First, genetics or familial. When we have one member of the family with varicose veins, the rest of family will have higher chance to have varicose veins. Increasing age, gender, females are more affected by than males due to sex hormones. Pregnancy, oral contraceptives. In pregnancy and oral contraceptives, there is the effect of progesterone hormone will relax the smooth muscles of the veins, leading to dilatation and varicose veins. Prolonged standing or sitting, obesity, prior surgery or trauma. Now, what are the clinical manifestations of varicose veins? Pain, leg heaviness, aching or tension, tenderness along the course of the veins, burning sensation, exercise intolerance, restless legs, paresthesia, night cramps, edema, skin changes, and itching. These are the main clinical symptoms of varicose veins. Now, the clinical signs of varicose veins. We have first special tests. The signs observed by doing special tests for varicose veins, and second, complications. So, signs are special tests and complications. Regarding special tests, I want you just to take a look for these tests, because these tests will be explained in details in clinical practice, okay, in the sixth stage, okay, just to have a look on them, okay, because they will be discussed in details in the clinical practice, okay. Now, complications. First complication is thrombophlebitis, that to say, thrombosis and inflammation of varicose veins, which is very, very common complication seen in clinical practice. Second, pigmentation, black to brown pigmentation due to hemosiderin from RBC breakdown. Eczema and skin dermatitis due to extravasated RBCs lead to itching and scratching, and eczema will develop. Okay. Lipodermatosclerosis, it means induration, fibrosis of skin and subcutaneous tissue. Lipodermatosclerosis or lipodermosclerosis. Chronic non-healing venous ulcer. Hemorrhage. This is a common complication of varicose veins. Bleeding from superficial varicose veins due to large due to high venous pressure in a large varicose veins. Sometimes even simple or trivial trauma will lead to profuse hemorrhage. This complication, Talb's equinovirus, is a rare complication to be seen in a patient with superficial varicose veins. It is actually a complication of chronic venous insufficiency. Even though it is rare complication. Progressive scarring around the ulcer. This will lead to permanent deformity. Now, what about investigations used in the diagnosis of varicose veins? First, diagnosis of varicose veins is mainly clinical, but we do use investigations to plan for treatments. The most common investigation tool is duplex ultrasound. Very useful, very handful tool of investigation, and very common used. Duplex ultrasound will give important information about the saphenofemoral, saphenopopliteal junction incompetence, valvular incompetence in the superficial and deep venous system, size of varicose veins, state of perforators, patency of the deep system also. Other investigation used are computed tomography or computed tomographic venography, CTV, or magnetic resonance venography, MRV, and venography. CTV, MRV, venography are less commonly used in daily clinical practice of varicose veins. They are used only when there is suspicion of deep venous obstruction as a primary cause of varicose veins. Okay. Now, when to treat varicose veins? You will see in the clinical practice a lot of patients having varicose veins for many years, and they even didn't seek treatment. So, when to treat varicose veins? First, symptoms. When the patient is really suffering from varicose veins, like pain, easy fatigability, heaviness. Second, complications. When complications occur, the patient will seek treatment, and varicose veins should be treated, like skin changes and ulceration, recurrent superficial thrombophlebitis, and external bleeding. Third, cosmetic. Some patients will no longer withstand the shape of varicose veins, distorting their leg appearance. So they will seek treatments. Now, what are the lines of treatments of varicose veins? We have conservative treatment, sclerotherapy, surgery, and endovascular techniques. Endovascular techniques, we have two endovascular techniques. First, endovenous laser therapy, EVLT, or endovenous radiofrequency ablation. Now, what are the conservative measures used in the treatment of varicose veins? First of all, leg elevation. Second, avoid prolonged sitting or standing, no leg crossing, exercise, weight reduction, of course, and compression stocking therapy. Elastic stocking. These are the main conservative lines in the treatment of varicose veins, and they are really helpful in reducing the pain and edema. Now, sclerotherapy. What is sclerotherapy? Sclerotherapy, a chemical agent is injected into the vein, irritating the venous endothelium and producing localized phlebitis and fibrosis, thereby obliterating the lumen of the vein. Okay? Examples of sclerosing agent used: hypertonic saline, polydocanol, sodium tetradecyl sulfate. The procedure is a simple procedure. It's an outpatient procedure, can be done under ultrasound guidance or even without ultrasound guidance, and it's usually used in cases of spider veins, telangiectasia, and in cases of reticular veins. So used in varicose veins with diameter less than 4 millimeters. But nowadays, sclerotherapy can be used also in the treatment of larger veins, like truncal veins and tributaries of great saphenous and lesser saphenous, not only the smaller varicose veins. Now, other line in the treatment of varicose veins is surgery. We have two types of surgical techniques. First, ambulatory phlebectomy, or what we call stab avulsion technique. This technique is used to remove clusters of varicosities greater than 4 mm in diameter with preservation of the greater and lesser saphenous vein if they are unaffected by valvular incompetence. So, if the great saphenous and lesser saphenous vein are normal with normal valves and the saphenofemoral junction or saphenopopletal junction are normal, they are not incompetent, so we will use only stop avulsion technique. Can be done under local anesthesia. We use a special phlebectomy hook to avult the varicose veins without any suturing. Can be done under local anesthesia. Now, but if the great saphenous or small saphenous veins are diseased with incompetent valves, then we need to use another surgical technique called Trendelenburg procedure. Trendelenburg procedure. So, in this procedure, through a groin incision, we ligate the saphenofemoral junction and separate the great saphenous vein from the common femoral vein. All tributaries should be ligated. Then a special device called stripper is introduced into the great saphenous vein and the vein is stripped. This process is called stripping. So, Trendelenburg procedure means high saphenous ligation, saphenous stripping with stop phlebectomies, removal of clusters of varicosities with removal of great saphenous vein or small saphenous vein. Now, what about perforators? If we have defective valves or incompetent valves in the perforator system or in the perforator veins, these valves or these disease perforators should be treated unless very high recurrence of varicosity will appear. Now, how to deal with incompetent perforators? Either we use endovenous ablation like laser or radiofrequency to obliterate the perforator, or we use subfacial ligation, either endoscopic or surgical ligation of incompetent perforators, or stop avulsion, surgical treatment of perforators. Now, endovascular techniques. As I said before, we have endovenous laser therapy and radiofrequency ablation. This is a very commonly used method of treatment of varicose veins nowadays. It gradually replaces the surgical treatment. Whether laser or radiofrequency ablation, a thermal effect created by laser or radiofrequency beam will cause obliteration of the vein. This procedure is safe, simple, and effective procedure. It is done as an outpatient procedure and without general anesthesia, under local anesthesia, with mild post-operative pain, and early return to normal activity. Okay, that's all about varicose veins. Thank you very much. Our next lecture will be about chronic venous insufficiency. Thank you very much.